Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. The sooner you spot cancer, the better. And in this case, Kristin Baker was able to spot her own cancer before ever seeing a doctor. That's because Kristin works as an ultrasound tech. One day, she was demonstrating how ultrasound works using her own body as an example. But as she moved the wand over her body, she noticed something was wrong and was staring at her own ovarian cancer tumor. Kristin is here with us today to share her remarkable story alongside her doctor, Dr. Andrea Jewell. Dr. Jewell is the Division Director of Gynecologic Oncology at the University of Kansas Cancer Center. Welcome to you both.
Thank you.
Is it nice to be sitting here together?
Yes.
It is. We were just commenting on, we look so, we don't get to see each other all with makeup on and dressed up that often.
Right,
so
yeah. Right?
We're enjoying that.
Well, glad you could be here for the occasion. Kristin, we're going to start with you. Just to clarify, you're an ultrasound tech, you don't work here at the health system, but take us back to this scary discovery where you were working. Why were you giving yourself an ultrasound? Kind of tell us what was going on in that clinic room.
So I had a student at the time. We had a break in our schedule, and the best way to teach our ultrasound students is some hands-on, and I could give her some more one-on-one, give her tips and everything. I was like, why don't you just go practice on my abdomen? No big deal.
And that's something you've done before?
Yes. So she was scanning me, and I was like, okay, something's not right. And she even picked up on it. I was like, I'm actually really proud of you, but let me see that, go get my coworkers, and just to kind of.
Because you were looking at the
Well, I saw like a bunch of fluid, and
Okay.
I kind of checked both sides, and I went down to my pelvic area, and I was like, uh-oh.
So you grabbed the wand from her instead of going to town.
And so I told her to go get my coworkers, because I'm like, am I really seeing this? It was just kind of surreal, and I just wanted other eyes on it, and it was just the craziest thing.
Yeah, when your coworkers came in, what did they say? What did they think?
They're like, this doesn't look good. So then we went to my doctor, and I made an official appointment, and then he recommended I get a CT and an official ultrasound done.
So we have an image of your ultrasound. Was this taken later? Was this what you saw at the time? Tell us about what we're looking at.
So that's the official ultrasound. So what we're looking at is, you can see my uterus there. The black is the fluid, and then up next to the uterus is the tumor that we saw.
So walk us through the next steps. How did you end up here at KU Cancer Center and in the hands of Dr. Jewell?
So my doctor asked me, where do you want to go get this biopsied? And I said, KU, that's probably the best place for it. And then after I got that, they recommended me to the best doctor ever, Dr. Jewell.
Right.
And
here you are.
Here I am.
But before you got to Dr. Jewell, what was that time like for you? How were you managing that? You're in the healthcare field. You probably know a lot already, but how are you handling this before you even got that official,
Honestly, I probably was like in a fog, like this isn't really happening.
You're 29 years old at the time, too.
Exactly. This is not something you expect before you're 30 or even at any age. I was like, oh, it's everything, like kind of like in a delusion, like everything's fine, like it was the craziest thing.
Well, and then just the discovery itself, how it all came to be.
Yes.
And just so glad it happened in that fashion so that you could get to Dr. Jewell. So Dr. Jewell, tell us a little bit about Kristin's diagnosis, what stage it was at. Was it aggressive? How did you tackle this?
So Kristin was diagnosed at stage 3C, which is the overwhelming majority of ovarian cancer patients are advanced stage. We unfortunately don't have great early screening for ovarian cancer. So she was diagnosed at stage 3C, and she had a serous ovarian cancer, which is just what I say, it's like what it looks like underneath the microscope, because there are multiple types of ovarian cancer. The most common is this serous epithelial type of cancer. What we do know is that ovarian cancers, many of them respond really well to chemotherapy. Patients have a really robust response, and we'll talk a little bit more about some other aspects of her ovarian cancer later, but she very much fell into that category of patient that had a really robust response to chemotherapy.
I was going to ask you if there was any good news, because we know late stage, not good news, but the fact that you're responding to the chemo is the good news. And we talked 29 years old, not even 30 yet, newly married at the time. This is not on the radar. Is it usual to see this in someone this young?
It's not, unfortunately. So she is a rarity in that. And then we'll talk a little bit more about genetics and family history playing a role. But it is unusual to see an ovarian cancer in someone under the age of 30. So she fell into the not as common category.
Right, and we talked earlier about, before we went on air today, just about trying to decipher some of those symptoms, because that's going to be big questions out there to people listening is, how do I know? And you, like many people, Kristin, have GI issues. I mean, get in line. A lot of people have that and just kind of ignore them, and they're just kind of part of life, and, you manage them the way you manage them. But Dr. Jewell, tell us a little bit about what those are, and how do we know the difference and when it's time to get checked out?
That's a hard thing, because
the $1 million question.
Yeah, absolutely. We all feel bloated sometimes. We all have,
Sometimes I feel it all the time. So
exactly.
Right.
Our appetite's off sometimes.
You travel and you feel weird.
Yeah,
and your bowels aren't doing what they're supposed to do.
I'm a little bit constipated, or gosh, I'm achy today. That's a really common thing. And normally what I tell people is that all those things are really normal. If you notice you've gone 2 weeks and those things are persistent, go get checked out.
What if they go away and kind of come back over 2 weeks? Okay, a day you're better, then a couple days you're not. Then you're going back and forth.
If they're still persistent, because they may wax and wane a little bit, but if you, on a daily basis, those symptoms are coming back, go get checked out. Because also, what's the bad part about that, right? You go somewhere and someone says everything's fine.
Good. Thumbs up. We like that. Good peace of mind. But Kristin, what were you feeling day to day, and for how long?
So kind of the same thing. I kind of felt bloated, but again, I went to one of my best friend's wedding down in Texas, didn't eat the best. And then the weekend after that was 4th of July weekend. Again, didn't eat the greatest. So I had bloating, some abdomen pain. I just felt full fast, but didn't think too much about it. And I don't know how long I would have let it go on. It's just the scary and most unreal thing,
Absolutely. I want to show a CT scan of Kristin, and I want you to just tell us, what are we seeing here?
Yeah, and she had already kind of circled some of the areas, and these are always hard because you're just kind of looking at a lot of black and white blobs. But essentially, those large white areas that are circled, those are all the areas that was her tumor that had grown. And so the stuff that's in the bottom, that's in her pelvis, and we think that's the ovaries growing. But you can also see in the upper abdomen, her cancer had already spread to other places in her abdomen. And that's what made this advanced stage. So she actually had cancer not just on her pelvic organs, but had also spread to other places in her abdomen, which is very common.
And how important was it, though, that she caught it when she did? Had this gone on another month, 3 months, 6 months, what would we be looking at? Resistant to treatment, or?
Maybe not resistant to treatment, but it can be more difficult to get it to shrink down significantly, because we treat ovarian cancer with a combination of chemotherapy and surgery, and so we don't want to go and do surgery if we don't feel like we can safely get everything out. And so you can imagine if these tumors are really large and they're next to large parts of bowel or blood vessels or places that we can't really safely operate on, that can impact that. So the fact that we caught it earlier means the chemo can shrink it more efficiently to make surgery an option.
So I was going to ask what the treatment plan was, surgery and chemo, and that's basically it.
Yeah. Well, and then we'll talk, when we talk about the genetics component as well, one of the newer, more exciting things in ovarian cancer is we now have an option of maintenance therapy. And there's a few different types of these medicines. They're called PARP inhibitors. So it's a pill that you start after you complete surgery and chemotherapy. And we know that BRCA patients respond really well to PARP inhibitors, and so we're now on a maintenance therapy for her. So we're still treating this to make sure that it doesn't come back.
So you had the chemo, hair loss, kind of what we think of with typical cancer treatment. How was that for you?
I mean, losing my hair, it wasn't the best. It was definitely a very cold winter, so if I forgot my hat, I definitely remembered got to go back inside. But the actual chemo itself, going through that, it was awful. I'm not gonna lie there.
Tell us how did you get through those days?
So I actually kind of had an allergic reaction to both my chemos. So we had to reduce the dose and then like do it very slow, like pretty much all day. I was in the treatment center for 2 days all day getting both of my chemos, and after that I was super nauseated, super tired. I just wanted to stay in bed pretty much.
Yeah, it took its toll. Like, not an uncommon story we hear, Dr. Jewell. So let's talk about the genetics. Your mother was diagnosed with breast cancer. Tell us a little bit about that history.
So she was diagnosed with breast cancer at age 42. She beat it. Went 10 years, and then she got diagnosed with a different kind of cancer that's similar to ovarian, but it's called primary peritoneal, where it just started in the peritoneum rather than the ovaries. And then she got her genetic testing done during that time and found out she was also a BRCA.
So Dr. Jewell, kind of unpack that. What does all that mean? When we start with mom, she's young, and then just that road we follow down genetic testing.
Well, what we know from the data and looking at other families is that typically the next generation will be a little bit younger. So if we're seeing mom being diagnosed in the 50s, and we think 10 years earlier, we need to be thinking about risk-reducing surgery, we need to be thinking about preventative measures. Unfortunately, in this situation, it was more than 20 years earlier, so it really, really came at a much younger time. But so we do use family history in our genetic patients to help us determine what preventative measures and things we need to do to help prevent these cancers, because honestly, cancer prevention is the best way, than even catching things early. We want to just prevent anything from happening.
And you just mentioned it, just before we had these prevention surgeries, you're basically just, or even before the genetic testing, you're just waiting around like a ticking time bomb. Waiting to get that. Is that how, that's how that could have felt, right?
Yeah, because like when my mom did her genetic testing, they told me, all right, be ready like mid-30s to get a double mastectomy, get a full hysterectomy just to reduce your chances. And here I was at 29, like, oh, it's happening now, I guess. So
did you have the full hysterectomy?
I did. I did.
And you're young, you're married. Tell us how that's impacting you as a young woman and wife and mother to be, possibly.
So it was definitely really hard with how advanced my cancer was. Like, going and retrieving eggs, it was not a very good option. So we pretty much just, me and my husband, we went full in, like, let's fight this and then we can figure it out later.
So decided not to do the egg retrieval.
Yeah, I was told it wasn't a very good option.
Gotcha. And why wouldn't it be a good option for someone at that age?
Well, we always, especially with young patients, try to do all fertility sparing options that we can. And unfortunately, with her cancer starting on the ovaries, her ovaries just weren't behaving normally. So if we tried to do the retrieval medicines or different things like that, her ovaries wouldn't have responded in the way that we would have been able to retrieve eggs.
But does that mean that anybody diagnosed with ovarian cancer is not a good candidate just because it's ovarian cancer?
Not necessarily. Okay. So we do have some early stage, if it's just isolated to one ovary, we do have some patients like that we can do. We refer them to our infertility specialists and we work together. But if it's involving, in her case, both of the ovaries, and chemotherapy inhibits the ability even of just a normal ovary to be able to make eggs and do things like that at the time. They'll wake up afterwards, but if the ovaries have cancer on them, they're just not going to react normally and eventually.
So do you mind sharing a little bit more about how this has affected you? I know you said it did deeply in the beginning. How have you moved through that, and you and your husband?
Like during all my cancer stuff, like I focused more on beating this and everything. And this year, since I feel like I've beaten it and everything, we're doing good. It's just like, oh, this kind of stinks, we wanted to have a family and all this stuff. And I do ultrasounds and I scan first trimesters, second trimesters, all the fun stuff that I'm never going to get to experience or have that. But I feel blessed because I do have littles at home that are my honorary nieces and nephews that are just my world. I adore them. I really do. And they help me get through it. Just their smiles and them telling me they love me. And me and my husband, we talked about maybe someday in the future doing adoption or something like that.
There are lots of paths to expanding your family. And I feel like just listening to you, being around you, it's like you're right where you're supposed to be. Even when you just said it's nothing worse than to say that opportunity's been taken from me, but you're able to be there with other women going through it, and that sounds really hard, but you just seem like you're doing what you're supposed to do. So I appreciate you sharing that. You've had a lot of support too, right?
I did.
How important just has cancer support been, especially your spouse, partners, they're everything during this. Tell us a little bit about this guy.
Oh, that guy.
That guy.
He's the best. He literally has been with me through thick and thin. I mean, we're going through our vows right now, through sickness and in health.
Yes.
And
a little earlier than you thought you were.
Right. But he's been my biggest cheerleader, my best nurse. I mean, not only him, but, you know, my family and my community, they all just kind of embraced us. And I mean, I don't know what I would have done without their love and support and care and messages and everything. It would have been very hard, but having all of that behind me, it made me feel like I wasn't fighting this alone, and it just gave me hope and that I can do this.
Yeah, people to lean on. I know there's a photo we have, just a shout out to some other folks that, again, that's quite a tribe around you.
Yes.
Cornhole.
Yes, that was one day of a whole big weekend. We also had a softball tournament that weekend that one of my cousins organized for me. I felt very blessed. It was a big fun weekend of just a lot of people having fun, playing softball, playing cornhole, just getting together. It blew me away with how much support I truly had from my community and family and friends.
Right. Dr. Jewell, how important is that? I mean, just knowing that when they leave your office, they go home and they've got like a soft place to land.
Yeah, you know, as a healthcare provider, I really see both ends of that spectrum of seeing patients. I mean, she literally had a community rally around her, and that's incredible. And then I see patients, on the other end that they don't necessarily have that much support. And as you were talking about the long days of chemo and how you're feeling afterwards, having that is really critical to being able to get through all of this.
And it's hard to imagine somebody not having that support. We're going to be doing a show here in the next coming weeks about just places that people who are diagnosed with cancer and different types of cancers where they can find support and friends and social media and make their own, find their own support.
Yeah,
you know, we've got to do that.
Absolutely.
All right, so if you have questions, be sure to ask them. Use the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. Info is right there on your screen. Let's check in with Dr. Dana Hawkinson. COVID count this morning.
Yeah.
How are you?
Hi, I'm good.
Good. Good morning.
COVID count is up just a little bit from the last 2 weeks. We've had 14 active patients. Right now we have 16 active patients. I'm happy and optimistic that it hasn't gone up any more than that. Again, we know the virus is circulating out there. I think we all know people or have heard stories about people who have it. I know even in the high schools, there are a lot of kids that are out there. Some teams that are being reduced in the number of participants just because the kids are out because of COVID. So it is circulating out there.
All right, a couple questions here.
Yeah.
Okay, so we're still waiting on the new COVID booster, but the flu shots are available. It's that time of year. The CDC has a new ad campaign targeting specific groups of people, and this is the slogan, wild to mild, as in the flu vaccine can tame the flu, or another way of saying it, the vaccine might not be completely able to stop the flu, but it will make symptoms way more manageable. The ads are specifically targeting pregnant women and parents of little kids. CNN reports that vaccine rates are down among infants and children. That's good. That's not good.
That's not good.
But do we have any more information about that?
I think that is it's disheartening for sure, because it is those most vulnerable, those children that can't make their own decisions on vaccine or not. When those levels are low, you don't provide that protection. Now, I think we need to continue to increase and improve our messaging. Again, the vaccines were made to help reduce your chance of hospitalization and severe disease for COVID, but also for influenza. We know right now, I think there's data coming out of South America, several countries, that it is a good match this year at this point in time and has significantly reduced the amount of hospitalizations for influenza. So it's vitally important for those most at risk. Again, immunocompromised, those people with different comorbid conditions. age, particularly the elderly, but also pregnant women and those that are particularly young, under 5 years old. It is vitally important to get vaccinated against influenza to protect yourself and, of course, the baby against severe disease and hospitalization. We know that the influenza vaccine can do that, and luckily our earliest data right now, again from South America, suggests that there is a good match and that there is good efficacy against reducing hospitalization.
All right, so I have not gotten my flu shot. Is it time?
Yeah,
Okay.
I think right now we don't have as much circulating influenza virus in the country. If we could hold off just a little bit. But if you are flying, traveling, maybe going to be in an airport or other stations, bus stations, train stations, it probably is a good idea to go ahead and get it. We never want to miss an opportunity to vaccinate. We also want to make sure you have that long-lasting immunity through the respiratory viral season, which is typically going to be now through April. So again, if you have that opportunity, never miss that opportunity to vaccinate. But talk with your medical provider and really figure out that best timing.
All right, Hawk, thanks so much. Any reporters with us today? Let's get to our community questions. And Yen wants to know, can abdominal ultrasound detect cysts and blockages in the fallopian tubes?
Yeah, it can. So there's a special type of ultrasound that it's like I'm explaining this and I realize like she could explain it really well as well.
Because that's
what she does. But where you essentially put like a special type of fluid and it goes to see if the fallopian tubes are open and if they're working normally. Ultrasound's very good at picking up ovarian cysts. The hard thing is just seeing a cyst, you know, what I always say is my eyes are not a microscope, or the ultrasound probe is not a microscope. And so we have certain things that can look concerning on an ultrasound, but you really don't know if something is cancer until you take it out and look at it under a microscope. And there are sort of extreme examples like her where there was like a very large obvious tumor, there was fluid. That's a more obvious, yes, this really looks concerning. The majority of cysts we see on ultrasound falls somewhere on the spectrum in between.
Gotcha. Okay, so on that note, Jennifer wants to know, does Kristin feel like her medical background helped her while being a patient, or does that just kind of go out the window and you're just a patient in that moment?
See, I feel like having a medical background, it's kind of scary that you almost know too much. But I feel like the information that helped me the most was kind of going through all the treatment with my mom. I knew what to expect. I knew that it was going to be hard. It was just, yeah.
I think that's also, I mean, that was one of the things I was very mindful of when we first met, was that, holy cow, this woman has seen her mom go through this. I mean, there's, you know, that really just goes into, okay, that's scary. Like, it's scary to go into the unknown, but when you've seen someone go through all this hard stuff, that really adds a deeper emotional kind of weight to what you're getting ready to go through. And that was something my nurses and I were really cognizant of every time we were together, and really, you know, trying to also ask, like, is this bringing back? You know, I mean, that's like traumatic. Like, there can be like a PTSD component to that.
That's the mental health aspect of it. Right. When should, Rachel wants to know when I should get genetic screening for cancer genes, and then how do I even go about doing that?
You know, I encourage everyone to meet with a genetic counselor, essentially, like, because there are a lot of complicated algorithms to what type of genetic testing we should be ordering, and if we should be ordering genetic testing, or if you're someone that should just have usual cancer screening. And so I really encourage everyone to meet with a genetic counselor, because there are patients that I may look at their family history and I don't think it looks that concerning, but they meet with a genetic counselor who says, oh, we should actually be sending all of these different tests. So I would encourage, especially if you have a strong family history of cancer, meet with a genetic counselor. Certainly if you do the genetic testing and it's negative, all that's going to do is help reassure you and figure out a screening plan.
I want to get our takeaways today, and Dr. Hawkinson, can I start with you today?
Yeah, absolutely.
Kind of threw you for a loop there, because we usually end, but I just wanted to get your thoughts, takeaways. What should we do? I told you, I was like, I hadn't gotten my flu shot yet, but you're saying, you know, that's okay, we can wait. What else do we need to know?
Yeah. Well, again, I think going back to the headline about the campaign, again, we know vaccinations are down overall, and it's unfortunate, especially for those most vulnerable, those people that can't make those own decisions, those children. We know vaccination is so vitally important for so many diseases to help reduce the chance of overall disease, but of course severe disease as well. And I think the new campaign by the CDC is really good, from wild to mild. We do know that the vaccines can reduce the chance that you will get that severe disease. We have good data to support now that the influenza vaccine for this year currently will help reduce your chance of hospitalization and severe disease, especially for those most at risk. Again, immunocompromised, the elderly, those people with chronic medical conditions, and of course the very young, those under 5. So it is time to now start thinking about getting influenza vaccine. We also know that there are other vaccines out there, particularly RSV vaccines for those that are 60 and older, and then soon there will be the new COVID booster, or will it even be called an annual vaccine? We will await the full recommendations from the CDC for that, but I think right now, if you are out there, if you're about, never miss an opportunity to vaccinate, please get RSV vaccine if you fall under that criteria, and get your influenza vaccination.
Yeah, 'tis the season.
Yeah.
Doc Hawk, thanks so much. Dr. Jewell, what's the takeaway today?
This is always my soapbox when,
Go for
so, you know, talking about the vague symptoms, the abdominal bloating, the cramping, the pain, and if you go in and get checked out, if you do not get a pelvic exam for those symptoms, you have not been examined. So if you go to a physician, if they don't feel comfortable or they just haven't done it, you need to go see a gynecologist, because what we can assess on a bimanual or doing a palpable pelvic exam is so much more than you can ever feel in an abdominal exam. So if you really want to assess if there's something wrong with your uterus or ovaries, you have to get a pelvic exam.
Okay, so
an abdominal exam.
What's you're feeling when they touch your stomach?
Yeah, like when you go.
Around?
Yeah, like so that's like an abdominal exam. A pelvic exam is like when you go to the gynecologist and they put the speculum in and they put their hands in and they feel around, and that is a much better exam to assess uterus and ovaries.
That is a really good tip. I don't think everyone knows that. So that is a great takeaway. Kristin, thank you for being here and just sharing your story. It's not always easy, but we appreciate you being here and educating. What do you want people to take away from your story today?
You know, listen to your bodies, be an advocate for yourself. If you have any concerns or questions, do go to your doctor, and just take care of yourself.
Well said. Thank you. Thanks to all of our guests. Thanks to all of our viewers for being with us today. We will see you back here tomorrow.
Coming up Tuesday on the Morning Medical Update, doctors say he's their miracle patient, not expected to live even days longer, yet years later he's thriving and starting his own family. I'm Alexis Del Cid on the next Morning Medical Update, the life-saving immunotherapy that made it possible, Tuesday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.